Good morning, everyone. Thank you, Team ROC and Dr. Parag and Dr. Amar. So, again, a similar repetition of a similar case. Again, a stiff hip. 29-year-old female housewife, known case of ankle spondylitis, with bilateral stiff hips and restricted mobility and difficulty in walking. So, these were the preoperative X-rays of that lady, the AP and the lateral. And this was a preoperative video. She was walking with a stiff hip, and the right side was around 4 centimeters short. So she's walking with a gait which is, you can see, so difficulty in walking. So, and this was the deformity on table with the right hip flexed.
So the right hip is basically the bigger problem here. The left hip is fused, but it's fused in a better position. The right hip is partially fused in a less. Right? That's basically the challenge here.
Right.
So let's talk to the panel. Which hip are we going to do first?
The right hip.
Yeah. I mean,
flexed,
that's the bigger problem, right? It's easier to position with the left hip, you know. So I think that's the challenge, and that's what we did. So
So my question to panelists is, any other investigations would you want to do for this patient?
We would get standing X-rays, and I'd get a CT scan, but you could.
Yeah.
We get a CT scan, and you want to image the spine. As we've heard, from the head, from the skull to the sacrum, to see if the cervical spine's fused, to see if there's a kyphosis, to see if there's any spinal movement. Those all have implications. We've talked about stiffness for the lungs. We've talked about the anaesthesia being complex.
Pelvic obliquity, you can check.
The diagnosis of your case, Hangsbond, the SI joint seems to be open.
Yeah, but she was HLA-B20 positive, and it was.
they're open, but they're sclerotic. But I think it's a good point that and a good observation that her SI joints are not fully fused.
Yeah.
So I think the bigger challenge, this is actually a pretty nice situation because she has that sort of normalish left leg where you can easily position her if you're doing a posterior approach. The challenge would be if she had the bilateral conditions of those abduction, flexion contractures, then positioning it is much more challenging. And you got to get very creative so you don't break one of the legs while you're doing, you know. But anyway, so yes, keep going. Let's get through this.
On true size X-ray, the templating was done and the size was 44. So what would be your bearing surface and your head size? What would you choose? So.
All right, so let's do the bearing surface. What's going to be bearing surface, Dr. Bosel?
Ceramic on poly.
Ceramic on poly.
Ceramic on poly.
Anybody want to do something other than ceramic on poly?
Well, you want the biggest diameter you can get.
We just told you that dislocation is not an issue.
Yeah, but yeah.
Okay.
You could use ceramic on poly. I'd probably use a monoblock ceramic acetabular component, get me a 36 millimeter bearing.
Okay. Resurfacing?
Yeah, just use a resurfacing cup,
Yeah.
and then
I'm just giving you a hard
36 head
time.
on it.
That's the delta motion he's talking about, which
Okay.
we don't get it now anymore in India.
Okay.
And what approach would you do? Anterior, right
We
anterior?
covered that. Most of them are posterior, one anterolateral, right? And you can do front and back if you have to.
So this was the sacral slope. She had not a very fused spine, but the mobility was restricted. So the change in sacral slope in standing and sitting was around 15 degrees. And what I did was I did a bilateral simultaneous hip for her. We did a direct anterior approach in supine position.
You know, looking at her back, it also starts to speak that maybe the diagnosis is called into question, right? So did she have a rheumatological evaluation?
Yes,
She had
I
all
did
those
that,
things?
and she was HLA-B20.
Because infection now, it's starting to creep into my mind a little bit more, and you know, there are other causes for spontaneous fusion of the hips.
But she was diagnosed with a HLA-B27 positive, yeah.
It's unilateral, and SI joint is normal. The spine looks normal, almost. And HLA-B27 can be a certain level of prevalence in the society without having an inflammatory
Many
disease.
times it is negative, but still the patient is an inflammatory arthritis.
The other condition.
But clinically, the hips were totally fused. There was no movement in either of the hips.
For an orthopedic surgeon, probably it is same, but for the patient.
Yeah.
Yeah.
So what I did was we did a simultaneous bilateral anterior approach, total hip replacement using Mako robotics with express pathway. And we took an in situ neck cut and we did the reaming with the help of the robot. And we could, so this is the Mako CT planning on the right hip.
Okay, good. Keep going.
And this is the Mako CT planning for the left hip. And we did simultaneous bilateral. We could, since the slope was not changing much, so we had reduced the antiversion to maybe 15 degrees because we did a VROM, a virtual range of movement on the software, and we could see that hip was impinging. Anterior and we posterior, and we reduced the version. And this is the post-operative X-ray of the patient.
Very nice.
And this is a post-operative video.
Great job.
And so my learning tips, since this is Angst-Pond, she was stuck sitting pattern, and we had to reduce the acceptable anteversion since the spinopelvic mobility was reduced. And what's more important is to find the exact central rotation of the hip and get it right in the center of where the implant should be. And you have to also, one important point is to prevent heterotropic ossification in future. You have to maybe put on some prophylactic medicines like indomethacin.
I think it's a reasonable thing
Can I
to
just
do.
make a comment?
Sure.
We do this spinopelvic analysis preoperatively, and we're trying to plan for the postoperative function of the hip. And in this case, when you've got very stiff hips, that's going to really change the way the spine moves, and when you fix the hips, it may differ. So that's something that we have to think about as well.
Yeah, again, I don't think we can recognize who are at risk, but then we don't know really what to do. But we're getting closer and closer every year. All right, thank you very much. Thank you very much.
One important point with Mako, you don't need to put screws in almost 99% of the cases. The cup fits so well that you don't need to use screws.
But the take-home message should not be like, use a robot, no screws, should not be the take-home. It's a bone condition.
Yeah. Yeah.
Just
There's nothing wrong with putting in screws.
small question. Especially when doing the bilateral like this, why did not use enhanced version of the Mako? Because you need to get this, the offset and the leg length comparison for both.
Why? Because I was doing a direct anterior approach simultaneous, and we have done a few cases with the enhanced pathway, but clinically we don't find much of difference. We get a good neck cut with the Express, and then we can do it simultaneously without much of a trouble. Because if I want to do a
So just to be clear, just for the audience's sake, you can do like an acetabular only version of the robot, right? Or you can do one that has the femur information as well, right? And it takes a little longer. You got to put pins in the femur and et cetera, right? So
there's one problem in that, because the patient, especially Angst-Pond, they can be having a poor bone stock. So there's a risk of peritrochanteric fracture. So that is one reason I don't use enhanced for such patients.
Okay.
And one more point about this DA is, even if you're not using enhanced, because it's a DA supine, you can have a nice good X-rays. You know, you can check that with a normal fluoroscopy and you can measure. Another thing is, did you lengthen the first side a little more, or was it equal or shortened?
So first side I would lengthen maybe by 2-3 millimeters. So I have a margin when I do the second side.